Thank you. I suppose I ought to declare my conflict of interest. I am indeed an ageing doctor. And looking at the demographics in this room, I think I'm probably not alone. I probably should begin by explaining to you my experience that brings me to the platform today, why I know some things about ageing doctors. For 10 years I worked as the medical director of the New South Wales Medical Board, as it was then, and in 2000 the Medical Board introduced a performance assessment program which was a non-disciplinary pathway for managing and remediating poorly performing doctors. Prior to 2000, and this is really the case internationally in regulation, the historical approach was to focus on a particular complaint about a practitioner and to deal with that complaint in a disciplinary framework if it met the threshold at the time, or to do nothing about it at all if it didn't meet that threshold. But a more contemporary approach to complaint management in regulation is to focus on the totality of the doctor's fitness to practice with remediation as the goal. So the performance assessment program that was introduced in 2000 was put in place to deal with doctors who came to attention mostly because of patient complaints. There were other sources of information, sometimes from colleagues, sometimes from employers, but mostly from patient complaints. And in the performance assessment program that was established, we had a graded response to the matters that came to our attention, and it culminated, if necessary, in a practice-based performance assessment. And the performance assessment in the doctor's practice is the process by which the care that the doctor gives to real patients is assessed and the strengths and deficiencies and any remediation needs are identified. The format for a performance assessment is that it's broad-based, it's triggered by a notification or a complaint, but in the course of the assessment we don't focus again on that triggering notification. It's based on clinical performance rather than knowledge, what the doctor actually does with real patients in a real setting. It's conducted by peer assessors in the doctor's own environment, if that's at all possible, and this is really where my experience stems from. I'm not the peer of many doctors that we've assessed, but what I've very, very regularly done is facilitated performance assessments. So I've had the privilege of going into doctors' practices while assessments are being conducted and observing them at work. And that's not something that many of us have had the opportunity to do, and it's given me an insight into the particular issues that ageing doctors face. And as I said, that the assessment centres around observed practice using multiple assessment tools. So why do some doctors perform poorly? There's a whole lot of reasons, but it can be lack of knowledge and skill, and this might be something to do with their inadequate training. It can be about failure to attend to their continuing professional development throughout the career. So they had the knowledge and skill at the outset, but as we heard earlier with EPAs, you get to a point where the curve starts to dip below that competent level and they're no longer performing adequately. And cognitive decline is another important factor. The knowledge and skill may have been there, it almost certainly was there at the outset, but is being eroded by a declining cognitive function. The other major cause of poor performance is an inability to apply knowledge and skill. So the knowledge and skill is there, but that for some reason there's an inability to apply it, and that might be a short-term inability or an enduring and long-term inability. And I talk about these things as being distractors, the things that distract an individual from being able to perform at their maximum capacity. And it can be things such as systems failure. If the system around the doctor isn't supportive and doesn't provide them with the tools and the wherewithal that they need to perform well, then through no fault of their knowledge and skills, they may not be able to perform well. Substance abuse, mental illness are other issues that can impact on a doctor's performance at any given time. And significantly, cognitive impairment is a significant factor. So I'm just going to show you some characteristics of doctors that have been assessed, and the source of this data is from the old New South Wales Medical Board from 2000 to 2010, which is when I worked there. I feel pretty confident, given that I continue to facilitate performance assessments, that these results would be probably pretty much the same now if I had access to that information. First of all, the practice type. And I'm showing you this because it becomes important later on in terms of professional isolation. In New South Wales, this is data is taken from primary care, general practice. In New South Wales, 80% of general practitioners work in group practices and 20% work in solo practices. And yet, amongst the population that have been assessed through the New South Wales Performance Assessment Program, 51% work of the poorly performing doctors assessed through the program. 51% are in group practice and 49% are in solo practice. So I think it tells us something important about the contribution of professional isolation to performance. Now this slide is a little bit complex, but it's quite important. If I can draw your attention, first of all, to, along the bottom we have age groups, and up the side we have the percentage representation in various populations. So if we look, for example, at the 45 to 54-year-old age group, the blue column, is that showing up well? Yes. The blue column are doctors who've undergone assessment. The purple column is doctors who've been found to be unsatisfactory through that assessment, and the pink column is the Australian peer population. So if you look at the 45 to 54 age group, they make up about just over 30% of the registered doctor population. They only made up about 17% of the doctors assessed, and they made up about 22% of the doctors who were found to be unsatisfactory through the assessment. If you look at the next age group, and I apologise to those of you who might find this a little bit close to home, as I do, if you look at the 55 to 64-year age group, you can see that there's a reversal there. That this age group makes up about 21% of the registered practitioner population, and yet it made up over 30% of the assessed doctor population, and it made up nearly 40% of the unsatisfactorily performing doctor population. And you can see that that trend continues in the 65 to 74 and then the 75 plus age groups. So it would seem that there's a significant tipping point somewhere between age 54 and 64 in terms of performance at work. And this is certainly borne out in individual cases that I've dealt with myself. So is poor performance secondary to cognitive impairment? Superficially, well-educated professional people may not seem to be impaired, and we've just heard about that. And if you're not thinking about it as a possibility, you won't think of it. I've been in practices of many older doctors who are urbane and well-presented and well-spoken and articulate. And superficially, you would not think that they had an underlying cognitive impairment. And yet, once you're alert to it and start to think about the clues, you become much more aware of the significance of the problem. So in the course of doing a performance assessment, during the course of a day-long assessment, there are clues, and we've become better at picking up these clues. I think at the outset of this program, we were quite naive to these clues, and it's taken some time to really piece them together and join the dots. So the sorts of things that we see in assessments that lead us to think that maybe there's an underlying cognitive impairment in an older practitioner is obviously knowledge gaps and knowledge erosion, things that you know that this doctor must have known at some point but doesn't seem to know anymore. Poor consultation structures and organisation, chaotic consultations that seem to go from history to examination to a bit of this and a bit of that with no real systematic structure. Very concrete views about what may be going on or what may need to be done without the ability to sort of flexibly think about other possibilities or options. And that inflexible formulaic approach to practice rather than looking at each patient as an individual. Difficulty multitasking, doctors who find it hard to talk to the patient, take notes, write the prescriptions, organise what's going to happen next, what the follow-up arrangements will be. And missing nuances, missing the clues that patients give to them. What's the patient really there for? When you're sitting in on the consultation, and it can be very clear to us as assessors that maybe what is being asked by the patient isn't actually the real reason that they came along, and yet the doctor's missing those clues, not picking up on those nuances. So these sorts of things, in a poorly performing older doctor, are the things that might lead us to think that the person actually has some underlying cognitive impairment. And the only way to be sure is to conduct some psychometric testing, and we found that to be, I still say we, I don't work at the now Medical Council, but it's hard to get out of the habit. Formal neuropsychometric testing is an invaluable tool, and I too have got a clock face. Now, this was a real case. I was involved in the assessment of this doctor. He was a gentleman in his early 80s and presented in just the way that I described earlier. He was personable and articulate and charming, but demonstrated a lot of those characteristics that I've just described. When he went for psychometric testing, did the clock face, this was his effort at drawing a clock face and putting the hands on at 10 minutes to 2 o'clock. And you can see that it's quite chaotic. Not only does he not have the clock face right, he didn't even manage to get the hands of the clock on at all, seeming to confuse a digital and an analogue clock in some way. Quite surprising. If you had seen the practitioner himself, you just would not have guessed that there was this level of cognitive impairment underneath. Different practitioner and a different test, very similar situation. This is I think it's called Trailmaker test, and the task is to join 1A, 2B, 3C, 4D, etc. It can usually be done in about a minute. This practitioner took 6 minutes and 58 seconds and made 14 errors, which are helpfully marked by asterisks, just in case you're having trouble seeing them yourself. It's an important question for us as regulators, and I guess for us as clinicians as well, is when a doctor demonstrates both features of both impairment and poor performance, what do you deal with first? Clearly, you've got to deal with their health as the priority. They're unlikely to be responsive to educative interventions if they're not well or if they're cognitively impaired. And my personal experience in visiting these doctors and talking to them extensively and trying to work with them about where to go next and what to do, they have some features in common. They generally have no retirement plan. They overestimate their abilities and fail to recognise their declining competence. They expect their colleagues to tap them on the shoulder. I hear this all the time. But in my experience, that's definitely not a reliable retirement trigger. It hardly ever happens, and in fact, colleagues are rarely in a position to know what's really going on in another doctor's practice. They underestimate or neglect risks and may work in practice that's an unsuitable setting. I facilitated an assessment just recently for an elderly doctor who is doing locums, and he will do a locum anywhere. He will go to a one-doctor town which has got an associated hospital, and he will work there as a locum. When we assessed him in a locum practice, he'd been there for 2 weeks. He didn't know where the emergency drug trolley was. He didn't know where the oxygen was, or if indeed there was any oxygen in the practice. Just completely oblivious to the risk that he was posing for himself. And they may also work outside their usual scope of practice. I used to think it was apocryphal, the story of the surgeon who would retire and then become a general practitioner, but I've actually seen it on many occasions, that somehow when you retire you can step into another area of practice for which you have no training and no experience. Is rather alarming. And these doctors are often professionally isolated, have very little contact with their colleagues, and fail to see the disconnect with their hope that their colleagues will somehow magically tap them on the shoulder when it's time for them to retire. And that harks back to that earlier slide about solo practice being a significant risk factor. So why do ageing doctors keep working, and these are the things that I've heard on many occasions. Financial pressure, often due to poor planning. One poor doctor I recall who'd been caught up in a Nigerian scam, lost all his money, lost all his superannuation in a Nigerian scam and had gone back to work. No doubt that was indicative of his cognitive impairment. I hope that this doesn't hit too close to home for any of you, but we frequently hear about older doctors who have got young families, second families, and kids to support through school and university who keep on working because they have that financial imperative. Many doctors are defined by being a doctor. They don't have any other identity other than being a doctor, and they're reluctant to give that up. They want to keep busy, and I suspect that a number of them that I've talked to don't want to spend too much time at home with their spouse, or vice versa. Maybe they've been sent to work because their spouse doesn't want to spend too much time with them. And it's common that they have no other interests, nothing else to occupy their time outside their work, and they feel that they're indispensable. So what to do? Poorly performing doctors only very occasionally come to attention because of notification from a concerned treating doctor or an employer or a colleague. So I think there's some lessons that we can learn from this. As teachers and mentors, I think it's really important that early in their careers we encourage doctors to plan for their retirement, both financially and socially. It seems like a long way in the future, but people really do need to be aware that those plans need to be put in place. It's no use waiting until you're 65 years old to start thinking about how you're going to fund and manage your retirement. As colleagues, we need to be alert to the possibility of cognitive impairment and be prepared to have difficult conversations. And they are difficult conversations. I think they're the same sort of conversations that you might have to have with your elderly parent about driving a car. It's the same kind of conversation, but it needs to be had. And I think we need to be prepared to notify the regulator if the conversation doesn't have the desired effect, because regulators have the ability to make things happen if you can't make it happen as an individual. And as employers, we need to recognise that the doctor may take the problem with them when they leave the workplace. The problem isn't solved because they retire from your institution. They may well go and work somewhere else or do locums in general practice in Timbuktu. You know, there's a broader responsibility than just managing the doctor in your own workplace. And I think the other thing to stress is that regulation has changed in the last 20 years. A notification to the regulator will not condemn the doctor to an ignominious deregistration or striking off. That's not how we work anymore. But the regulator does have the power to act if action is required. And every effort will be made to manage them with compassion and dignity, and that's certainly the way that we've been operating in the last 15, 16 years that we've been running the performance program. The last thing that an older doctor wants or deserves is to end their career with a disaster, and I think we all need to recognise that some of our colleagues really need help to ensure that that does not happen, and I'd ask you to all to be part of being aware of this possibility and assisting our colleagues. So thank you.